Well, welcome to another edition of the Giants and Chest Medicine, our video podcast. I have the honor today of interviewing and introducing you to Dr. Al Soffer. His accomplishments will definitively speak for themselves during our discussion. He was the senior editor for the Journal for the American Medical Association, and then transitioned to being the editor-in-chief for Chest, and was an integral part of the American College of Chest Physicians, and still is. He's going to discuss multiple different things, and what I think you're going to find most interesting is a look back at where the quality of medical journals used to be compared to where they are now. Amongst many accomplishments, I think you'll see there's a lot that we take for granted these days, and what is published and in our medical education, that people like Dr. Soffer are the reason why these are now the standard of care. Well, Dr. Soffer, thanks for joining us this afternoon in your wonderful home. There's your history in medicine and everything that you've contributed to the pulmonary profession is astounding. I had read some things about you, and then our conversations really, I think, illuminated things for me as to the things that I take for granted now are actually a byproduct of your work. And so there's so many things I want to talk about, but let's actually start with some of the things that from my conversations with you that I think make you very proud. So you were at one point the senior editor for the Journal for the AMA, and then ultimately left that position and became the editor-in-chief for Chest. Well, it was a different journal title, I believe, at the time. So I'm going to end with that open-ended question, and right there, and let you describe for our audience your path through the various prestigious journals that you've helped to grow, shape, and change, and I'd love to hear you describe that.
Kyle, it's a pleasure to be able to join you and have our conversation shared with health professionals through the internet. Yes, I left research and teaching in 1962 when I became, in essence, a full-time medical editor, first at the AMA and then with the American College of Chest Physicians. And I was fortunate. This was only about one decade after medicine welcomed the introduction of the controlled clinical trial. Until about 1950-51, medicine was really anecdotal. It was empirical medicine. But with the trial of streptomycin in Britain in 1951, we recognized that what had preceded us in medical research was unacceptable, that we now demand of anyone who introduces a new medication, a new diagnostic procedure, a new operation, we demand that it be proven effective or not effective by a controlled, randomized, double-blind clinical trial. Without that proof, it's anecdotal medicine. And so I entered medical journals at about a time when many medical editors simply chose the article by themselves without peer review. Well, peer review, to me, of course to all of us now, is critical. First of all, there's no perfect manuscript. We should offer the author the courtesy of increasing or improving the manuscript. And finally, we look very carefully to see, is this empirical medicine, or has the point been proved by the controlled clinical trial? Incidentally, I only wish that the American public would understand the difference between anecdotal medicine and controlled and scientific medicine. Look at the TV today, 5:30 news, any news, and you'll find interviews with an individual who says, I swear this is the best medicine, it cured me, etc. This leads to some terrible episodes. The promises we hear on television, in health books, on the internet, have potential, first of all, of frightening the public. Right. There's an episode when a national news station said, bypass surgery, where you have to cut into the chest, has many, many dangers. It frightened the American public so much that hundreds of patients who needed surgery refused to have it. It took us so long to get back to the truth. Gene Robin, Dr. Robin, had a magnificent book, Medicine, Risk versus benefits. In other words, there is no pill that's entirely safe. Aspirin, which has meant so much to especially American men over the age of 50 and now women, aspirin has potential dangers. Any life-saving operation has potential dangers. So in medicine, we evaluate the risk versus the benefit. So let me conclude by saying that peer review, to prove that we've gone from empirical medicine to scientific medicine, is critical for the medical profession, the researchers, but I only pray that the public, which is now being bombarded by hundreds of thousands of fraudulent sites in the internet, are told by their physician what good medicine is and what fraudulent cult medicine is. I think we should heed the admonitions of Mark Twain. He once said, "Be careful when you're reading health books. You could die of a misprint."
I want to have you expand on the evolution of medical journals. I'm struck by what you said, that publications that would be considered published whatever the editor felt like going in. It didn't have a peer review. It didn't undergo a rigorous vetting by colleagues to determine if this indeed was good science and should be published and accepted as the norm for our profession. I find that amazing. You and I were talking earlier. Anyone's CV these days has a list of their peer-reviewed publications and their non-peer-reviewed publications, because you have to have peer-reviewed publications, and that wasn't the norm.
It was not the norm. I was shocked in 1962, 63, 64 to find editors of major journals who simply decided on their own without peer review. When I left the editorship of Chest, I'd accumulated in my computer 8,000 names of consultants I had used, some American, some international, that I had used personally to review major manuscripts. A single case report is anecdotal, and it has something to offer, but it cannot prove the efficacy of anything new. Even if you have 500 case reports, they're clinical observations, they're not clinical scientific medicine.
I'd like to ask you now about your time when you first became editor-in-chief of Chest. Take us through what you did with both that journal as well as your contributions to the college.
When I entered the offices as editor-in-chief of Chest, I was amused to go back to the history. The first first journal sponsored by the American College of Chest Physicians was called Sanatoria, indicating, of course, that in those days, pulmonary medicine was tuberculosis. With more sophistication, then pretty soon the contents of the journal began to talk about pneumonia. So suddenly we went to infections of the lung. The next step was asthma, then emphysema. And the physiology of these diseases became paramount. When they hired me, perhaps it was no accident that they knew that I was a cardiologist, and that what I would bring to the journal was a concept that the heart and lung are contiguous organs. You cannot separate circulation and respiration. So that what I tried to bring to the journal was the interface. And now you'll notice the current issues of Chest have that title on the cover, Cardiorespiratory Interfaces. The heart and the lung working together in health and disease. And I was proud to see that the college, in its journal, in its postgraduate courses, and in its international courses, insisted stringently upon the concept of peer review rather than empirical medicine. Mm-hmm. We grew as the subtlety, sophistication of medical research grew, and I was proud to be part of that growth process.
When you were actively involved with the college, as well as your role in the editor-in-chief of Chest, one of the things you and I had talked about earlier was bringing in all other disciplines beyond just cardiology and pulmonary, and as the field kept evolving, you kept evolving with it, and you made sure the journal and the college was evolving with it. Could you expand on that?
Yes, for example, the discipline of critical care was not known to me or to my colleagues when I first began to be a full-time medical editor. But as the important concept and discipline of critical care became a key part of medicine, we had a problem. There were pulmonologists who said, we're also in critical care, and so we're both. And the Critical Care Society felt that this was, well, that there was a conflict. So the president of American College of Chest Physicians and I flew to Dallas one day to say to their board of trustees, we are a team, let's work together. And working together, honoring their society and honoring the concept. Once again, if you look at the cover of Chest, you see the word critical care, a critical care society, as well as a cardiopulmonary society. We worked with nurses, critical care nurses, with the team approach, not antagonism, but the feeling that each had its role to play. So in the 25 years that I was in the college offices, I was thrilled to welcome other societies and to work with them in a team approach.
I think that's fantastic. It's again, I think it's something that my generation of physicians takes for granted. The idea of what Chest is now as a journal and what the college is like, and the realization that we went from a journal and a profession of tuberculosis only to where we are now as heart-lung physiologists with sleep medicine, critical care medicine, pulmonary, cardiology, surgery. I mean, you name it, right? I guess it's a big tent. Everyone come on in.
Another thing that thrilled me about being with the college, at the college, was its view of international medicine. Medicine is the international language. By the way, 90% of all scientific literature of all types is in English.
Right.
So that to have the name American meant a great deal when I was at the college in those years. Do you know of any other societies, other than the College of Chest Physicians, that have clubs or groups who belong to that college, who are under the intellectual academic control of the Mother Society? We had 32 chapters around the world. I visited most of them. And our aim was to help them teach the type of medicine that we're talking about. Not empirical medicine, but scientific, controlled clinical trial medicine. It wasn't easy, but they responded to us in Chicago with courtesy, and the world congresses and the regional congresses were things of joy. By the way, sometimes they have unexpected pleasures. My wife and I were in Kyoto for the American College of Chest Diseases World Congress in Japan, and we were greeted in the morning by the future Emperor of Japan. Crown Prince then, he rarely left the palace.
Wow.
But because one of his good friends was a chest physician, he honored us. He and his wife met a small group of us, and they were delightful people. We have the international structure of the college was unique, and we had congresses. When at the cocktail party on the opening day, doctors from countries at war greeted each other as friends. Doctors from India and Pakistan shook hands and laughed with me, with my colleagues, at the time that their countries were at war. When Israel was buffeted by Arab countries throughout the Middle East, I joined them in the comradeship, indicating that medicine is the international language of communication and I hope of friendship. I wonder what role it could play today.
It's amazing. I think you're right. I'm struck by the vision that was needed to take a society, a college that had it in its history at the beginning, a focused view on one disease state, taking that and expanding it, and then expanding it beyond even just the borders. That had to be a monumental effort on behalf of yourself and your colleagues to expand the college and the journal to reach such an international audience.
Yes,
That has to be very satisfying for you, I bet.
it was.
And some great trips, it sounds like,
They
too.
were wonderful. They were wonderful.
Where were your favorite places?
Oh, well, we were in
Besides
Spain.
Kyoto, that sounds amazing.
We were in Spain so many times,
Oh.
and the friendship was so great.
Well, someone had to do it, huh?
Yeah, and by the way, another example, the governor of the college in Spain was married to the Infanta, the sister of King Carlos. Both of them greeted me warmly at a luncheon. These are the benefits of being the executive director and editor-in-chief.
They're not written down somewhere, but they are definitely the benefits of being involved, right?
Right.
So we'll make a plug. Renew your membership. I would love to hear anything else that you want to expand on in regards to your time involved with journals and as editors.
Kyle,
there were other journals that you were involved with as well.
Kyle, I'm delighted to tell you how proud I am of the pioneering work we did in making Coumadin a safe drug.
Okay.
I want to tell you, this is where every country in the world, every doctor is indebted to the College of Chest Physicians. What occurred was Jack Hirsch and Jim Dalen, key officers of the college, organized a number of conferences on the use of Coumadin. And the college, after many, many, many years of deliberations and publications, which I was thrilled to publish, recommended the system we now use, INR, and INR at a level which is safe. We had a fair number of mishaps with Coumadin as it was being used, hemorrhage or too little thrombosis, and the side effects were very worrisome. Because of the college, and because of these conferences, and because of these publications in chest, I think every country is willing to say with pride that we use the American College of Chest Physicians recommendations on INR and the level of Coumadin. That's a magnificent contribution.
I would have prescribed Coumadin, but I had little to no guidelines from any amount of science to tell me what dose or where to guide myself from an anticoagulation perspective. That I was almost, if you will, winging it.
Well, let's put it this way. The guidelines were not adequate and potentially dangerous. The secure guidelines, INR, that we now use, for example, the orthopedic surgeons recommended 1.8 to 2.2, and they have few mishaps after hip placement or knee. But now it is safe. It came after a lot of deliberation and some important conferences and some important publications. So American College of Chest Physicians and its recommendations on Coumadin is a milestone in medicine, in my opinion.
Well, I think actually, given for lack of a better word, the popularity of the chest publication whenever the antithrombotic guidelines are updated would speak to exactly what you just said. I think it is still something that is a cornerstone for our college and for our journal.
Yes. Now, I worry a lot about medical fraud in cardiopulmonary medicine. I mentioned that the internet is an entry place for a great deal of fraud. I myself have appeared in court in 4, 5, 6 states to fight against chelation therapists, the people who use EDTA and claim it cures everything, including dandruff, heart disease. And it's awesome, the degree of falsehood, and there are clinics all over the country. Yeah. It's difficult to stop these cultists. They're snake oil masters and articulate. So if your patients ask, and they will ask, how do I identify legitimate practitioner from a cultist? You could say, look, there are 3 or 4 things that are the clues. Number 1, all these people say, oh, the editors hate us. There's a conspiracy of silence. I can't get an editor because he hates me. Number 2, the establishment is against me. The FDA, the AMA, they know that by giving chelation therapy, we can avoid the surgical fee of bypass surgery, as if bypass surgery is not life-saving when indicated. I mean, surgery can be conservative if you need it, and radical if you put a pill in and you need it. Thirdly, you can identify a occultist by the fact that he's got fancy, exotic ideas of disease. I called the chelation clinic in Chicago. And I said, do you treat emphysema? Oh, yes, emphysema. Do you treat heart disease? Yeah. How about stroke? How about asthma? Infinite, silly, unsophisticated ideas of disease. Number 4, they depend upon patient testimonials. Anecdotal medicine is not scientific medicine. I return again, I said it earlier. Please turn on the TV tonight to any major channel, and they'll all have something on the health every day. Every magazine has to have a health article. It's the thing to sell. And you're going to find an interview with somebody a person who says the operation saved my life, it's the greatest in the world. And so anecdotal medicine, we are buffeted by it day and night on the internet, elsewhere. Bad medicine.
It sounds to me then that as your career continued to evolve, your current work now and your involvement of trying to educate the public on becoming more critical thinkers, the same thing that you tried to do in your role as the editor-in-chief was to take our profession to a higher level. It sounds like you're trying to do the same thing then for society.
I think so. I think a skeptical citizenry is a boon to democracy. To believe every written word because it is written is what sometimes leads us into trouble.
Yeah.
I think that to educate the public on what is good and bad medicine is a potential opportunity and a responsibility of the public. If you were to ask me, Kyle, what one element in health has been, to me, the hallmark of the American College of Chest Physicians, I would say smoking cessation. From the day I entered the office in 1967 of the American College of Physicians, we fought the tobacco industry. We do to this day through education. I mean, the education material in the last 2 years from the college has been magnificent. There's a sea change in education. I used to give a 6-week course in smoking cessation. We recognize now that the average smoker needs a year. And instead of saying to the patient, you failed us because you went back remission, we say, we failed you as a doctor. We should have adjusted the dose of Wellbrutin. We should have done a different type of, but the college, through all of this, has been consistently a fighter against smoking industry, against smoking cigarettes. Why not? What other society more than a cardiovascular pulmonary society should know the dangers of cigarettes? And I might leave you with this true story about one of the great pioneers and an active member of the College of Chest Physicians, Alton Ochsner, the Ochsner Clinic, the old man, the grand old man. I worked with him in my first conference on smoking cessation, which the college sponsored. Well, I told the story in front of him. One day at Grand Rounds, he asked the resident to report the case. And the resident said, we have learned at Tulane that cigarette smoking, number 1, gives you increased cancer of the lung, increased cancer, of course, of the throat, increased cancer of the stomach, and even increased cancer of the rectum. So Alton Ochsner rushed up to the microphone and said, I always tell my patients not to inhale so deeply.
Were his residents scared to laugh, or did they at least laugh? I think that's also, I think, just one of those amazing things to think about. You've fought multiple uphill battles in your career. You changed the nature of how things were published and the quality of our journals, and that would have been hard enough because there you were just taking on the profession. Yeah. Now you're trying to take on, essentially society from the perspective of where smoking was considered the norm and okay.
We appeared in Congress yearly to try to educate, to solicit funds for pulmonary and cardiovascular research.
Right.
The first year I was in the offices of the college, I wrote to Pan Am, I think TWA and American, and I wrote to the presidents and said, as a heart-lung society, we plead with you, would you give us 2 non-smoking rows? That's all. And they all wrote back and said, it can't be done. That's where we've come from.
Wow. I think that actually is a fantastic legacy. That alone, let alone all your other accomplishments.
Well, now forgive me for being immodest, but I predicted in '68 there wouldn't, others I'm sure said it, but I said there won't be a radical change in smoking until we make it socially unacceptable. The spittoons disappeared in 1905 because it was social, but while smoking was socially acceptable, and it happened, and when did it become socially acceptable? When secondhand smoke was publicized. So people said, I don't care if he kills himself, but I don't want him to kill me or my kids. And that's when the new attitude of smoke, it's become a blue-collar habit in many ways.
I think that's great. So I'm always interested. I would, you've had such a profound and successful career. I would like, if you've got words of wisdom for a lot of the people who are watching this, who are early in their careers and envision themselves wanting to follow a path similar to yours. What advice would you give someone who's a physician right now, who's early in his career and would like to have a successful career similar to yours?
Well, for those who say I want to be in the forefront of medicine, pulmonary medicine, any kind of medicine, I would say for those who have the ability and the desire that medicine is becoming cellular rather than organic. We've gone from the heart, the lung, growth, we've gone to the stem cell. We've gone to study the biology, the pathology of the cell itself. And maybe that's the future of medicine, our better understanding of the cell.
Okay. I think that's great. Let me ask you, anything that you would do different from your career? Along the way, if you figured it out 5 years later, you're like, oh man, 5 years ago, if I'd only had gone left instead of right, kind of thing. Do you have anything that you would look back on and think you would have changed?
I think what I want to say is the opposite of what I've done differently. What I can't believe happened, it was so nice, is that to be a full-time medical editor, it's one of the great thrills. And I taught every week. I always had a faculty position.
Wonderful.
At Northwestern and elsewhere. So I never left the bedside. But I think that the editors are the teachers, not only of 100 people in class, but of thousands. And so I was lucky. I took a chance. I left the practice of medicine in Rochester, New York, to become full-time teaching and research, and then being a full-time editor. It's also good for a society, by the way, like the college, to pay an editor full-time because they have the time. Almost all editors in 1962 were half-time, part-time. There were only 20, maybe 25 full-time paid editors in the world then. I was one of them. And it pays. It pays scientifically, right, and it pays the society. I was just lucky. I chose a profession, I consider it a profession, which has been a great joy.
I think, they should probably pay section editors too, right? No? Oh, well. Where do you see the future of chest medicine going?
Well, changes in cardiology are occurring every hour, every day. We probably very shortly will go from invasive procedures, diagnostic, to external, to identify, for example, coronary thrombus. But I ask you, as a distinguished pulmonologist and bronchoscopist, why does pulmonary medicine move so slowly? So I'm really asking that the future, I think, will be phenomenally rapid in cardiology, technological advances, but I can't answer for pulmonary.
Yeah, I wish I had a better answer as well. You're right, there are times where it feels like all aspects of our profession are not moving as fast as they could. You always wonder, though, part of it is new things do come out, and they go through the peer review process. But you also wonder, and rather than rapidly adopt it, do I want to see what actually comes out and has longer term follow-up and becomes the norm versus what was a flash and excitement and then disappears. I don't know, though. It's hard for me to say. I'm definitely if you categorize people into the early adopter or late adopter, I'm an early adopter. That's my bias. It's a valid question and maybe a personal challenge.
So I turned it back to you, Kyle. But I have enjoyed enormously our conversation. I've learned a lot, and I hope I've shared.
I think you have. This has been fantastic. I always like to close and ask if there's anything else that I failed to ask you, or that you wanted to expand on or talk about. Is there something else that we should talk about?
Just to honor the memory of the founder of the college, Murray Kornfeld. We owe him a great deal. He was not a physician, but I honor his memory.